Okay, good morning.
Morning.
Just me and her now, just sit
All
up
right,
here.
that's right.
So
Come
she
on.
doesn't feel alone.
All right. Well, we're going to talk in a group this morning, small group. We went through the big crowd yesterday, but our goal is just to spend time. One of the disappointing things about our practice is lots of people come from far away. One of the good things is that you don't need lots of doctor visits after the surgery, and we've kind of pared them down so you don't need too many before surgery. So that's disappointing because it blocks us from spending a lot of time with you and developing the really good doctor-patient relationship. And so that's an issue. So we try and get around that by having extremely long clinics on the days when we do have you. So yesterday I think was pretty long. But the design of that is to talk with one another, get to know one another a little bit. And after today, I'm your doctor forever. So you can call me, you can email, you can come visit. There are no clinic charges. Of course, you live in
Phoenix.
Yeah, so it's not like super convenient. So it's a little bit, it's easy for me to offer unlimited clinic visits to somebody from Phoenix because how often are you going to come visit?
Well, I don't know.
She's only 5 hours.
Yeah, my husband plays poker, so.
Okay, well, you're always welcome to come. We do have people you saw yesterday, some people who live in the area, so you're always invited to come and there's no charge for it. But our goal this morning is to spend time. And so, first of all, you had yesterday comments from yesterday's clinic, anything that came up or that you thought of last night in particular, having been through that?
I just had an additional question. I didn't want to take time in the group yesterday about
Sure.
type 1 diabetics because my husband's interested.
Yeah.
But he's concerned that what happens if he gets low and he can't consume enough sugar to bring his sugar back up.
Right. The neat thing about that is he's already had kind of those experiences if he's a type 1 diabetic.
Right.
So he's had events probably in his life where he's gotten low.
Right, but now he can eat straight sugar without making himself sick and bring his sugar back up.
Right. What I was going to tell you is if you think of those times when he's had low sugar, the amount of food or liquid that he had to take in to get his sugar back up was pretty small. You know, he didn't have to sit down to a 7-course dinner to get his sugar back up. Usually he has to have, you know, a little orange juice or something like that, and that bounces your sugar up pretty easily. And after the mini-gastric bypass, that amount of sugar is trivially easy to take in. It is a concern that you could get low sugar, but we haven't seen that. And in the occasional events when your insulin dose that you select is off or something like that, we found that the usual kinds of things that you do for a type 1 diabetic who gets low sugar or a type 2 diabetic who gets low sugar are easily done for the mini-gastric bypass afterwards. So for example, I mean, we have Sandy here this morning, and so, for example, what did you have for dinner last night?
Last night, I ate really light. I just had some salad. That was
Okay. And night before that?
Night before we had, I made chili, so we had some chili and we had cornbread.
Yeah. So you can see you can kind of take in a pretty normal diet. There would be a risk if you get too thin, you know, it could make you malnourished. This is a weight loss surgery, so that's a slight risk, but it's pretty uncommon in our experience. So that that particular concern isn't a big one for us, fortunately. The flip side of that is, what are the risks, what are the problems if we don't do something to a type 1 diabetic and help get the weight down, things like that. There are some risks to think of from that standpoint. So
He's not hugely overweight. He's about 60 pounds overweight, but he's a big guy. He's just concerned because he takes a lot of insulin.
Right.
His blood sugar's under control, but he takes a lot of insulin, so he's starting to get resistant to it.
Exactly.
He has to start taking more and more.
Right, and so again, if you look into the future of that, that's kind of an unsustainable thing. You can't, there's no, there is an upper limit. You know, once you get to really high doses, then the sugar control gets out of whack and you've got a real problem. You get the ketoacidosis problems and things like that. So getting that under control makes a lot of sense to protect you from the complications that are not maybe tomorrow, but 5 or 10 years into the future. Other questions? Anything else?
The only other question I had was as far as the follow-up visits.
Yeah.
I know you say that we're supposed to come back here. It seems like most patients don't, so.
We would like you to come back.
Okay, so if I come back here, you're gonna want my primary care doctor to draw labs first, right?
Well, I think that's a good question. How often do we get labs in our patients post-op? Once a year.
Okay.
Unless something comes up, you don't need lots of labs. Now,
Okay.
we sometimes have people in the medical field or a new physician who hasn't worked with my patients in the past, and they'll get lots of labs kind of for interest. You know, just want to watch my triglyceride. I want to watch my liver function tests or things like that. And so we have had people get those kinds of labs, but we don't do them unless you have symptoms.
Okay.
If you say I feel weak and tired, if I'm nauseated or something like that, we might check labs or have your doctor check labs. But routinely after the surgery, if you remember from the manual, you're supposed to get labs once a year.
Okay.
And you get a lot of labs. You know, we want to look everywhere, high and low, for the potential problems, particularly low vitamins, low minerals, something like that. But once a year is plenty, unless something comes up.
Okay.
Mama, any questions that came up over the night or anything since yesterday that we ought to chat about, or
No,
no medical technology questions or something from?
no, I don't, well, it doesn't really matter because Jamie doesn't have diabetes, but I don't really understand how the surgery stops
Diabetes.
diabetes.
How is it diabetic?
Yeah, it does, and we're talking about, there are two different things,
Yeah,
type 1 and type 2.
Right, the type 2.
But let's talk a little bit about type 2 and how it stops type 2 diabetes. Type 2 diabetes starts out in a thin person who then gradually begins to gain weight. When they're thin, type 2 diabetics in general are not diabetic. That is, their sugars are normal. The definition of diabetes is the morning of after fasting, you measure your blood sugar, fasting blood sugar, and it's under 120. So if it's under 120, you're not diabetic. That's the definition of diabetes. Now, as people gain weight, they become, and you use the exactly correct term, you use the term insulin resistant. So as you get heavier, insulin, which is designed to take sugar and put it in the cells, becomes less effective. When it binds to the cell wall to do its business, it doesn't work very well. You become insulin resistant. So your body, in a newly developing type 2 diabetic, says, oh, I can handle that. I'll make more insulin. So you can find people who are not diabetic, but you can measure, called our medical technology team, and we can say, measure my patient's insulin level. And you'll find that even before they have an abnormal blood sugar, their insulin level will start to go up because they're resistant with the obesity. The increased fat load in the body makes the insulin's effect less, and so the body is doing what your husband's been doing with his insulin pump. Your body's pancreas says, I'll put out more insulin. Now, when it happens, there's a paradoxical, unfortunate side effect of increasing the insulin to overcome the insulin resistance, which is more sugar is put into the cells, which makes more fat. So the person oftentimes gets heavier. So that an obese person at age 20 is not as obese as they were, is not as obese as they're going to be in age 25, and they get heavier at age 30, and heavier at age 35, and heavier at age 40. So insulin is high. Insulin is released at a higher level to overcome that by the pancreas. That makes you heavier, and so that you become more insulin resistant. So the pancreas says, no problem, I'll make more insulin, which makes more obesity, and you get into a vicious cycle. Now, once we operate, your weight loss begins to impact, so you become less insulin resistant. Your pancreas makes less insulin, and you go back down. Instead of a vicious cycle, you get a virtuous cycle going down. Your pancreas can only make so much insulin, so at some point, insulin resistance overwhelms the pancreas's ability to release insulin, and you get elevated blood sugars. and you're actually diabetic. So the weight loss decreases insulin resistance, and as you lose weight, the insulin itself becomes more effective, and finally, as there's enough weight loss, the diabetes goes away. Now, even something beyond that happens that we don't quite understand yet, and we talked about the mice yesterday. So we could take a mouse who's diabetic, and we could make them lose weight by putting the mouse on a diet. So we could find an obese diabetic mouse, put him or her on a diet, and we find that with weight loss we can make the diabetes go away. And that works in people too, type 2. So they said to themselves, as part of an experiment, they said, does the weight loss that comes from surgery do anything different than just losing weight on a diet? So they took mice and put them on a diet who were obese diabetic mice, and they took mice who were heavy and they did a gastric bypass. And they watched the weight loss in both of them, and for the same amount of weight loss, the gastric bypass mice got more resolution of the diabetes than the weight loss alone. And the reason they think is there's a hormone in the upper gut, the duodenum and the upper jejunum, which affects insulin resistance.
Because I have a friend at work that just had, I'm not sure what kind of bypass surgery she had. That, you know, it's like the day after surgery they said, well, you're not a diabetic anymore. I'm like, how can you get a gastric bypass and not be a diabetic anymore? It didn't make any sense to me.
It's a good question, and oftentimes we find that abnormal blood sugars, and we had this very nice lady here from Canada who was sitting over there who was on 50 units of insulin twice a day, which is usually a pretty hefty dose, plus 3 anti-diabetic medicines, and she hasn't taken a single dose of insulin or her anti-diabetic medicine since the day after surgery. So oftentimes that bypassing of the upper gut changes the hormonal mix right away. Yeah, that's one of the positives of the surgery, of course.
Another thing is too, is you're eating small meals frequently, so your blood sugar is a lot more stable and level than eating big meals and having it peak and then drop and peak and drop. I mean, if you think about it, you know, I think another way that you could probably relate that eating and blood sugar going up.
Let's see. Phoenix. What do you do in Phoenix?
I'm an analyst for Verizon Wireless.
Good. What have you found out about? What have you analyzed?
I analyze inventory.
Okay, good.
So my life is just one spreadsheet.
Is that right?
Yeah.
Good.
Oh, so you won't be able to tell me how to download my pictures off of my my
Q
queue
phone.
to my computer. You can't help me with that, huh?
No, but I'm
Send them to
changing
Pic's
the
place.
ringtones on my new
Oh,
phone.
that's what everybody says. You have to email them to yourself. Well, that's what I finally
email
found
them
out.
to yourself, or you can email them to, they have an online thing where you can send them to.
Oh.
What about that new phone that's coming out that does everything?
I haven't been in customer service for 3 years.
Oh,
so
okay.
I don't know
I thought
anything about
They like to give you
that.
guys the option to purchase it and enjoy it first.
Yeah, no, well, the
So are
company
you guys
pays
going to
for
have the
my
Apple
phone, so
iPhone, or
I don't know.
so
I'm
we're
so
going to ask
far
you
out of the loop now.
Well, don't you keep up on your company
I'm
and
a
like kind
bad
of stay? You're a bad employee. We'll
It's
cut
either
that
those
out.
company emails that come out about all the new stuff, I'm just like, delete.
All right, she wants to get
So you're not out like pushing people to choose Verizon?
No.
Got your car painted with please select Verizon. You don't know the Can You Hear Me Now guy?
Oh yeah, I had my picture taken with him.
Oh,
He
seriously?
came to one of our team meetings. Test man. Yeah.
That's pretty cool.
The Can You Hear Me Now guy?
Yeah. Actually, Las Vegas is one of the markets that I handle
Uh-huh, okay.
for inventory.
So how's our
But
inventory?
I didn't tell the manager here I was coming,
Okay.
otherwise he would have made me work.
Yeah, okay. How's our inventory
How much
here
is that worth to
in
you?
Las Vegas? Are we okay?
No.
It's messed up.
I didn't care about inventory until Sarbanes-Oxley.
Okay.
you know, and then once all that, with Enron and all that hit and all the new government regulations, now we
Right.
have to actually show that we own what we say we own.
Oh,
Now we have to prove it.
I see.
So
That's what you do.
each cell site has about $1 million worth of inventory in it that has to be tracked, serialized and tracked.
And we didn't used to do that?
No, because we didn't care. We knew what we were doing.
Yes.
But now we have to prove to the public that we actually physically can prove that we have this inventory that we
That's
bought.
right, because you advertise it.
So we're not embezzling all this money.
I see.
You know, that's what happened with Enron. They said they bought stuff that they didn't really buy,
Oh, is that
and the
right?
money went elsewhere.
Ah,
So
Wasn't
now,
that like
That's
bonuses?
right. So can't you do that on your Excel spreadsheet? You know, just kind of, multiply times 4.
Yeah.
it's not worth going to jail for, huh, Jamie?
Well, the one guy died, right?
Yeah, I think the
He was supposed to go to jail. I mean, he actually died after Enron, right? One of the ones, the Enron guy? Okay, let's see. Other questions, let's see, we should talk about. How'd you find out about us in the first place?
just off the internet.
Okay. Now, does that kind of generate some skepticism to find some doctor on the internet who claims he's the best? And I'd just like to volunteer and tell
It
you
did
that.
until I started talking to people.
Okay,
You know, I joined the Yahoo group right away.
right, listened in.
Right, and then started emailing people.
Mhm. How long did it take you to go through the whole process from when you first saw it?
It was fast.
Yeah.
Because I had already
Oh, okay.
thought about gastric bypass a long time ago. I just didn't think Roux-en-Y was worth the risk in my situation because I'm not that unhealthy.
Not that heavy, right?
So I had already thought about it, and then when I found something that was less risky, it was just a matter of getting the packet together and getting the money together. 3 weeks, less than 3 weeks.
What about the lap band? Did you think about that, or do you want to talk about that a little bit?
I did think about the lap band, seriously, because my insurance will pay for it.
Right,
But it has such a high failure rate.
right.
The people just don't lose weight.
Do you know somebody, or you've heard of
No,
someone? Yeah.
I don't know anybody personally, but.
Yeah.
you-
Well, I can tell you, I was at a meeting this past weekend where we had lots of surgeons from around the world who were talking about their experiences with the lap band and the Roux-en-Y. And one of the things they talked about is that if you're doing lap bands, you need to get ready because you're going to have a lot of them come back. And so they showed lots of videos of how to take out the lap band and what to do for it. One of the disappointing things that I heard from these specialists was when you fail your lap band or Roux-en-Y, their explanation was the patient was not following instructions. In other words, if you have my surgery today and you don't lose enough weight, what's the explanation? You're a bad patient. That really is very satisfying as the surgeon, because then you can't blame the surgeon, right? Instead, you blame the patient. And so they had a panel of all these people, and they were talking about patients who failed to lose weight. And all of them were saying, well, they have psychological issues, they're nibbling, they're not doing their exercise, they're not doing these things. And we don't take that tact. So, for example, we have Sandy today who hasn't lost enough weight. And she's going to have a revision with us, and it is her fault. No.
Well, I blame it on my family genes.
No, we think that at the
It's the
time of...
Irish American Indian, I would
Right.
say.
We think at the time of surgery that if we bypass enough, then it's going to give you good weight loss. If we bypass too much, you'll get too much weight loss. And we've actually had one person out of 100, a little less than that, who have had excessive weight loss. And conversely, if we don't bypass enough, you won't lose enough. And we don't blame the patient. We think that's entirely related to the surgery. So our expectation is that you'll have good weight loss. But we have seen a few patients who don't lose enough and a few patients who lose too much. And that's related, we think, not to patient compliance, which is kind of what the surgeons were saying at this conference. They said if you don't succeed with the lap band, it's because you're a junk food eater and you're not listening, you're not paying attention to what you're supposed to do. And so they had a psychologist get up and talk about doing MMPIs and things like that to see whether or not you'd be a good candidate for the surgery. My bias is that those surgeries and those patients don't succeed very often because the surgery isn't that good.
Yeah, that's what I decided about the lap band. And I wasn't comfortable with the idea of having a port on the outside and having to fill it, and
Right.
just didn't seem worth it.
I had a person call yesterday and interested in our surgery, and he said, of course, his whole family is big, his kids are big, he's big, and he wants surgery for himself and 2 kids with a discount. And I said, well, it costs the same. But anyway, he said one of his daughter, who was like 380 pounds, has had the lap band. She's had it for almost a year, and she's lost 140 pounds. But she tells her doctor she has to go in every couple of months and get things tightened up, and she tells her doctor how she wants it done.
Mhm.
It's like he was going on and on about this, and I
Well,
just
if
was
she's done
thinking,
so well, why is he having our surgery?
because he doesn't think that she's going to do well later. That's what he said. He goes, right now she's doing well,
Yeah.
but what's going to happen in a year or two? And I says that she'll probably come and see us if you
That's
do
right.
well.
That's
So,
right.
so
Yeah.
that's what.
Right.
So it was interesting to talk to him about his whole family yesterday. So he's on the board now, looking at stuff. So.
So 6 feet, Sandy? Another 6
Yeah, I
feet?
think so.
Yeah, I think that's
That
right.
was what it was with Trish, right?
I think so. And I think if we do less than that, there's a risk, if we do additional 6 feet, but I think we
Right.
should.
Okay. Well, like Cassie, you did, and she was only going to get a gastroplasty. That was her first thought, and that's why I told her 6 feet because of our family. That's my niece, Jamie, in case you don't know. So Trish has had the surgery, and me, I'm number 2. My son, Ben, is number 4. I needed 7 feet on Ben.
Yeah.
And then Cassie was just, probably she was, 80 pounds overweight. Yeah, was 220, and she's 5'4". So, and she was just thinking of a gastroplasty, but after looking at Trish and I and how our body acclimated to the weight loss so quickly, she decided to go with 6 feet. And she's actually right on target.
Yeah, I think so.
She's
Yeah.
lost in a month.
She was like
or
24.
Yeah, she lost.
So she'd lost 10%
10%.
of her body weight in the first month,
Right.
and that's the average, so that's
Right,
good.
So she's doing well.
Other questions? What else should we talk about? My background, how we invented this kind of surgery. Any of those interesting or interested or?
Well, I was thinking about that while I was laying in bed this morning, because at your clinic yesterday, you were like, I've done blah, blah, blah. I was like, well, what did you say at the first clinic? Because you couldn't say that then. That you've
It's a
done
very good
3,000.
question. Yeah, that's right. The first clinic, if you think about it, let's go back to that day, September 1997. And at that time, I had spent about 20 years as a professor of surgery at the University of North Carolina in Chapel Hill. And my primary responsibility was I was a trauma surgeon and a specialist in critical care. And I also did the old open gastric bypass and stomach stapling, which I can tell you from years ago, that's not that great. I had a Thursday clinic and I did cases every week. I did 3 or 4 people, and I think I helped some people, but abscess, infection, hernias because of the big incisions, it's not anything like this. In 1988, there began a revolution in American medicine where somebody came out and said you could take gallbladders out through a TV camera. That was 1988. And soon after that, can you hear me now, guys? And soon after that, we started doing laparoscopic gallbladder surgery. And over the subsequent 10 years, from 1988 to 1997, I kept thinking that there would be mechanisms to use those laparoscopic tools to do my surgery, the weight loss surgery that I was doing. And in 1997, I started doing laparoscopic Roux-en-Y gastric bypass. I wasn't crazy about it. And on the evening of September 1997, I was on call for trauma, and a guy got shot doing a drug deal in downtown Durham, North Carolina. Got shot 6 times with a .357 Magnum in the belly, and I got him up into the operating room about 9 o'clock that night, and I cut away the lower part of his stomach and a bunch of other different things that were shot and hooked him together the way you're about to get your stomach hooked together. That is, the stomach to the intestine. That's a standard technique. It's nothing new to me. It's been done for over 100 years for all kinds of reasons to hook the stomach to the bowel. And it went really smoothly. I got him up into the intensive care unit, and the next morning a friend of mine was about to have a laparoscopic gastric bypass with me, and I told her, I think we should use this other connection, the loop, or what's called the Billroth 2, instead of the Roux-en-Y. I said, it's a lot simpler. It's what I just did last night for this guy who was shot, and I think it's going to be smoother and safer, and there's all these other advantages. And she said, fine. So we did that, and she did great. And the next patient did great. And so at the University of North Carolina, did 64 cases that did pretty darn well, and I was so impressed with it, I quit my job as a professor of surgery and over the past 10 years, I've just been talking to people about doing this particular kind of surgery. And that's the story.
So what did you say at your first meeting then?
The first meeting I said, I don't think the Roux-en-Y is a very good choice. We do this all the time for gunshot wounds and ulcers and other stuff. I think this is a better choice. And I have done 3 people and they all did great. And they said, okay. And so then I did 10. I said, I've done 10 people and they all did great. And then I had done 1,000 and I thought the whole world, I thought once I'd done 1,000, all my colleagues, everybody would realize, well, you've done 1,000 cases, that proves it. And I did 1,000 cases and people still said, well, it can't be that good. You must be fibbing about how short it is and the complications and the weight loss. People told me initially they won't lose weight because the stomach we make is bigger than the Roux-en-Y stomach. And they said they won't lose weight because I don't make the connection, what's called the anastomosis, really tiny. You notice that our patients can take pills and they're not vomiting all the time. So there are a lot of doctors who want that connection to be very tight and narrow so you can hardly eat anything. And we found that you can have good weight loss with a good normal size connection. And so early on in the first 100, they said, well, it won't be proven until you've done it for 5 years. Well, I've done it for 5 years. They said, well, you know, they've constantly got a reason. Although we are starting to see that change. But your question's a good one. In the first couple of people, I would just say, well, I've got a lot of experience. I've done other kinds of surgery, and I've done 10 people like this, and I think it would be a good choice. Plus, the other thing about this particular kind of surgery is, let's suppose it doesn't work. That would be terrible. It would be a tragedy. But we could undo it. You know, we could undo it, and if you say you get a craving for a Roux-en-Y, it's easy. So the nice thing about the surgery is its revisability and reversibility. So we like that. There's a new surgery that's gaining a lot of support called the sleeve gastrectomy. Have you heard about that at all? Well, it has got some positives. It's basically like the stomach that we create, but the problem with it is you can't get it back. You know, there's no way out. There's no reversibility to it. And there was a group of surgeons advocating the sleeve gastrectomy at this meeting I was at, and you know, I wasn't impressed with their results. It gets less weight loss. They often say you have to come back and do a second surgery to convert the sleeve gastrectomy into something called the bilio-pancreatic diversion with duodenal switch. So that's a really complicated and much more dangerous surgery. So I don't think that the sleeve gastrectomy is going to be a huge positive either. So
Why can't you reverse it? Is it the connection? Or?
when they do the sleeve gastrectomy, they actually cut out 90% of the stomach and throw it away. They do it just like we do, but instead of leaving that stomach there, they cut it all out and they take it out.
That's frightening.
So there's no way back from that.
So if you get sick with another illness, you're basically a
TPN,
goner.
you got to be intravenous feeding. There's no way out from that because the part that you need is gone. So.
Do they have the risk of also probably losing too much weight, like some of our patients that you've had to revive?
No, it's more like the sleeve is unlikely to lose too much weight. It's much less effective. It's more like as effective as the band. The best studies of the band show an average weight loss of about 70 pounds. Our average weight loss is 140 pounds. And if you think our surgery has a small stomach, which is kind of like the band, kind of like the sleeve gastrectomy, kind of like the stomach stapling, it does part of our surgery is contributing about 50% of its effectiveness. Small stomach helps a little. Small stomach plus bypass, then you get the major weight loss. If you just do the small stomach, then you're going to get some weight loss and then gain that back. That's the band stomach stapling experience, and the sleeve is starting to show up that same way. So what they talk about is going back and cutting out more of the stomach for re-sleeving people who have lost some and gained it back. So keep trimming that stomach down. And in fact, that's what we'll do in your stomach today. You know, we'll look at it and trim it a little. Other questions? Okay, well, get ready, get set.
Okay.
We'll see you all in a little bit.